Everybody, good morning. Yeah, I'm Paddy Wilson. I'm one of the radiologists at the Norfolk and Norwich Hospital. And I've been asked to talk about, it's a bit of a mouthful, a radiologist's guide to systematic interpretation of CT of the petrous temporal bones and MRI of the IAMs. Now, that's not entirely correct because I'm going to, or at least half of it is correct. I'm going to talk primarily about CT of the petrous temporal bones and mention in passing MRI and where it fits in. Let's see how we go. So the aim of the talk really is to talk about some of the indications for imaging, which modality to use and when, and look at the important and relevant CT anatomy. And then we're going to finish with a few cases by way of a quiz. Okay, so it's a fantastic bit of anatomy to get to grips with, and I suppose part of its fascination is that it's so small, yet we can image it beautifully. And the reason that we can image it beautifully is that we have high resolution CT with reconstructions that can go down to less than 1 millimeter. And in fact, with new cone beam CT, we can take it a stage further as well. And the reason CT is so useful is that we have dense bone within the petrous temporal bone, and then air within certain structures. So the mastoid air cells, the middle ear cleft, and so forth. And this allows us to see the very, very fine, detailed bony anatomy. So CT, fantastic for looking at the contrast between dense cortical bone and air. CT is also great for anatomical variations, which we see pretty much in every petrous bone we look at. There's always going to be some variation, whether it's to do with pneumatization of the mastoid air cells or other features. It's great for detecting early and subtle bone erosion. We can analyze the ossicles and assess whether there's continuity between them. It's great for looking at the bony facial nerve canal and the Otic capsule structures. And perhaps most importantly for you guys, or for most of you guys, it gives us a good roadmap for the surgeon. Okay. MRI, once we get out of that air bone area, is where MRI comes into its own. So it's much, much better at soft tissue discrimination. So once we get into the posterior fossa, looking at the IAM and the CP angles and the brainstem and cerebellum, that's where MRI holds sway. But it's also very, very good at looking at the Otic capsule structures with high resolution T2 weighted techniques. We can get some fantastic detail from the Otic capsule. And then inevitably there's an overlap between MR and CT. And MR is particularly useful in some of the intracranial complications of petrous bone disease. So once disease has passed from the mastoid air cells or the middle ear cleft into the intracranial compartment, that's where MRI can really be very helpful. So these are just a few of the indications that we use for both CT and MR. And the first few on each side are where those two imaging modalities hold sway. So CT is particularly useful with inflammatory disease and cholesteatoma, patients with conductive hearing loss and trauma. I don't think anybody would argue that CT is the indication of choice in those issues. And then there are some rather grayer areas where often we will choose to use both CT and MR. So particularly the vascular otoscopic mass may need MR to complement the CT. Necrotizing otitis externa, I think we'd kick off always with a CT scan, but we may choose to follow up or monitor patients with MR. Malignancy inevitably often uses both modalities. They give us different information and can be very, very helpful. And as I've already said, looking at the Otic capsule structure, CT is very good, but MR can add something. And in the context of youngsters with syndromes, both CT and MR have a role to play. MR holds sway in patients with sensory neural hearing loss and vestibular symptoms, and then also the complications of inflammatory disease. Okay, and then there's an overlap: necrotizing otitis externa, malignancy, Otic capsule issues, syndromes. Perineural infiltration is one area that, again, MR holds sway. So if you've got a patient with a facial nerve palsy and known parotid pathology, you're probably going to use an MRI to see if there's infiltration up the facial nerve canal. MR is much more sensitive at that. You often won't see an abnormality on the bone CT scan. Okay, so this title, or the title of the lecture, has got systematic in it, and I'd have to say that systematic doesn't really come very naturally to me. I think some radiologists are naturally systematic, and then others like me struggle at it. But this is a really good area to be systematic in, because I think there are some things that are always going to leap out at us and we can recognize them immediately. But there'll be others where you actually need to go look in order to see an abnormality. And I think the petrous bone is one area where that holds sway. So my natural approach is to work from the outside inwards. So starting at the external canal, looking at the bony external canal. Is there anything, is there any soft tissue within the external canal itself? Moving on to the tympanic membrane. Can I see the tympanic membrane? Because in most instances where the tympanic membrane is normal, I wouldn't expect, or just a very, very faint representation of the tympanic membrane on a normal CT scan. We should be able to see all three ossicles and fine detail of those three ossicles. And then moving more centrally still, looking at the oval window and the footplate of the stapes. You've got to keep your eye out for other stuff as well. So you've got to be mindful of the anatomy of the adductus, the mastoid antrum, the distribution of the mastoid air cells. Okay, every patient is going to be slightly different. Don't forget the petrous apex. The roof is important. It's often thin and can provide a gateway into the intracranial compartment. Okay. And then I'll have a look at the facial nerve canal, the Otic capsule structures, always mindful of anatomical variations. And don't forget the stuff more inferiorly, particularly the jugular foramen, the carotid canal, and so forth. Okay, so there's quite a lot to look at. And what I'm going to try and do is work from essentially external to internal and just go through the anatomy of these individual areas. Okay. So here we go, sort of very basic standard axial CT through the external auditory meatus. And we're going to make sure that the bony margins should be nice and crisp, no erosion, and we don't expect to see any soft tissue within the external canal. If we do, it's often wax. When you see soft tissue and erosion, that's when the alarm bell should start ringing. And in this patient who's got a normal ear, excuse me, we don't see the tympanic membrane at all, but we'd expect it to be sort of slung in this sort of orientation. Other things to be aware of in this slide: this is the horizontal portion of the carotid canal. This is the petro-occipital fissure separating the petrous temporal bone from the occipital bone. And this is the sigmoid sinus with the well-corticated sigmoid plate. If we have a look at a coronal image of the external canal, again, we expect to see nicely defined bony structures. And I think this is one area where normal variation is quite important, particularly with respect to the structures above the roof. It's fair to say sometimes you get a whole sack of pneumatized mastoid air cells here and a relatively thick wodge of bone between the intracranial compartment and the external canal, but sometimes you get no aeration and just a relatively thin plate of bone. And this obviously has implications if you're thinking about drilling into this area here. I think go easy would be the watchword. This pointy structure is scutum. It's a variable length, but it should have a nice sort of pointy. This is about the best example of a pointy scutum I could find. And the superior aspect of the tympanic membrane attaches onto scutum. Okay, and then its inferior attachment is inserted onto the tympanic annulus, which is this raised portion here. And again, we don't really see the tympanic membrane here because it's normal. So other things to be aware of: tegmen tympani, the very thin plate of bone separating the excuse me, the mastoid air cells from the intracranial compartment. We can see the ossicles, and we'll have a look at those in more detail. Remember this little space here, okay? It's where pars flaccida cholesteatomas typically occur, and we're going to keep revisiting this area as we go through the talk. We've got the oval window, horizontal facial nerve canal, vestibule, and the semicircular canals, and the first turn of the cochlea and the internal auditory meatus. So let's have a detailed look at the ossicles, and we should be able to see all three ossicles, and we should be able to see different parts of those ossicles. So as far as the malleus is concerned, we should be able to pick out the head and the neck. We should be able to pick out the handle embedded in the tympanic membrane. And then sitting behind that, or sitting behind the head of the malleus, we have the body of the incus, which has a short process and a long process. And then finally, the long process articulates with the body of the stapes, which has two crura and a footplate that inserts into the oval window. And we should be able to see all of those things on a well-performed CT scan. So these are, I think it's fair to say, when I'm looking at the ossicles, I'm primarily using axial imaging to assess whether the ossicles are normal or not. And I think they're the easiest modality, or the easiest orientation to assess whether there's any subtle erosion, or whether there are any unusual, whether there's unusual anatomy, whether there's an unusual gap between the ossicles, whether bits of the ossicles are missing. I would say the axial images hold sway. So we're starting quite high up in the attic here. So mastoid antrum at the back, attic at the front. The anterior most ossicle is the head of the malleus, and just sitting behind it is the body of the incus. Okay. And as we go down, we can begin to see the more typical ice cream cone shape of the incus and the ice cream in the cone, which is the head of the malleus. Okay, next section down, the cone of the ice cream is seen there in all its glory with the ice cream. And the short process of the incus sort of pointing towards the, from an orientation point of view, is always aligned along the long axis of the mesotympanum, the middle ear cleft and the mastoid antrum. And as we continue going down further, the ossicles change in shape. So if we just concentrate on the malleus to begin with, it becomes more rounded as we go further down and thinner. And then it becomes slightly broader, and you can see its relationship with the tympanic membrane. So here's tympanic membrane, and this is the handle of the malleus. So this is where, you know, tympanic membrane vibrates. This is the first bit of the ossicular chain that starts to move, the handle of the malleus, and everything follows on from that. If we go back up from there, so from the handle to the neck, it's worth just picking out there's this little structure here, soft tissue structure, which is the belly of the tensor tympani, okay, which inserts into the anteromedial aspect of the middle ear, just above the eustachian tube. Okay, so this is the belly of the tensor tympani. And as the tensor tympani ascends, it hooks round a little pulley, the processus cochleiformis, just in here. And from that pulley, you can see a little structure. I don't know whether you can appreciate that on your scans, but you can see it heading here towards the neck of the malleus. okay? And that's the tendon for the tensor tympani, okay, which is involved in damping vibrations as necessary from the ossicles, okay? And that's supplied by the third division of the trigeminal nerve, okay? If we just go back to the incus now, okay, so sitting behind the body of the malleus, here's our cone-shaped incus. As we head down, it becomes much thinner into the long process of the incus. And this is probably the most vulnerable bit of the ossicular chain. First of all, it's very narrow, and it probably has a more tenuous blood supply than elsewhere. So if it gets damaged, it has a limited ability to repair itself. But in normality, we should be able to follow it all the way down. Remember that at the tip of the long process, there's another little right angled bend, a short little curve at right angles called the lenticular process. And it's that articulates with the body of the stapes. Okay, so this is the lenticular process here, and then we're probably onto body of stapes just here. And then coming up towards the oval window, we have a posterior crus and an anterior crus. Here's our oval window, and here's our footplate of the stapes, filling the oval window niche. And there again, you can see the anterior crus and the posterior crus. Here's our oval window, and here's the vestibule, okay, on the other side of the oval window. So one other dampening ligament that's worth knowing about is a ligament that's attached to the stapedius, and this emerges from this structure here. This is the pyramidal eminence, okay, so it's a raised structure on the posterior wall of the middle ear. And you can see it's got a slightly lower attenuation center. That's the belly of the stapedius muscle. And it sort of looks a bit like a volcano. And emerging from the tip of the volcano, I don't think you can see it very well on these images, the tendon of stapedius is going to insert typically onto the body of the stapes, but sometimes on the posterior crus. And then two important recesses, okay? One to the medial to the pyramidal eminence, which is the sinus tympani. Doesn't really contain anything other than air, okay, but it can be very variable in its depth. And if it's very deep, you can hide all sorts of things in there. Particularly if you've got cholesteatoma in there, it can be quite difficult to get out. So it's just a good normal variation to sort of get your eye into. So that's the sinus tympani. And on the lateral side of the pyramidal eminence, we have our facial nerve recess just in here. And sitting behind the facial nerve recess is the facial nerve itself, okay, which is that little dot there, okay. So let's just have a look at that in coronal section. I suppose one thing I didn't actually mention was the middle ear cleft and how we divide it up. And generally speaking, if you draw a line from scutum to the horizontal facial nerve canal, anything above that line we're going to call attic or epitympanum. Anything below that we're going to call mesotympanum. And then there's a very shallow trough inferiorly, okay, which is the hypotympanum, which as I say is very shallow. So this is a coronal image through the cochlea, which we can see quite nicely here. So we're relatively anterior. This is largely malleus here. You can just about make out the tendon for the tensor tympani. Remember this space, okay, Prusac space, okay, just at the top end of the tympanic membrane, just below scutum, okay, that little recess there, that's where cholesteatomas, pars flaccida cholesteatomas start. And you can see why, because of that, sorry, let's just go on to the next slide. Because of that, scutum is very vulnerable, as are the ossicles. And you'll often see cholesteatoma heaping up in this part of the attic, just here, eroding the scutum and the ossicles as they go. Okay. This is a little bit further anteriorly. So we're onto the basal turn of the cochlea and the vestibule at this level. We can see the oval window in here very nicely, but we can also see that lenticular process of the incus. So this is the long process of the incus, and this is the lenticular process of the incus. And then we have our incostapedial articulation at about that point there. Okay, just in here. as I say, it's very, very difficult, I would argue, to see subtle erosion on the coronal images, and I'd always use axial images to assess the ossicles. Let's go through the otic capsule structure. So we're going to be looking at the oval window, the vestibule, semicircular canals, the cochlea, and so forth. Okay, and so again, another section, another series of axial images taking us up through from the vestibule. Okay, so we're through the inferior part of the vestibule here. There's our footplate of the stapes. Remember this little area here. Okay, it should be really nice, dense bone, dense cortical bone, as we can see here. This is typical spot for otosclerosis. Okay, so you may typically see a lucency here with some heaping up of bone around the anterior end of the oval window. Classical site for fenestral otosclerosis. Okay, here's the posterior semicircular canal. So remember, we've got the 3 semicircular canals roughly orthogonal coming off the vestibule. As we go up, posterior semicircular canal, a bit more of the vestibule. Again, posterior semicircular canal. There's a little blister here on the back end of the petrous temporal bone, which is the endolymphatic sac or opening of the vestibular aqueduct. The vestibular aqueduct's very variable. If I just toggle up a little bit, that's the vestibular duct there. It's very, very tiny. Okay, as a general rule of thumb, it should be at least the same or narrower than the posterior semicircular canal. It's a pretty good rule of thumb. If it's bigger than that, then you may well have a giant vestibular aqueduct. Now we're on to the horizontal semicircular canal. Okay, and this is quite nice because it shows us the attic just above the ossicles. Here's the additus of the additus ad antrum, and then the mastoid antrum behind. Okay, so vestibule, horizontal semicircular canal, and that's one crus of the posterior semicircular canal. As we go up, we see the common crus for the posterior semicircular canal and the superior semicircular canal, and still heading northwards. You can see how everything joins up. So that's the sort of top end of the posterior semicircular canal, and that's the top end of the superior semicircular canal. Okay. Let's just have a look at that in coronal section. So now we're starting posteriorly. This is our posterior semicircular canal just here. As we move forward, you can see the curve of that posterior semicircular canal. Here's our horizontal semicircular canal moving forwards onto the vestibule. Here's our superior semicircular canal. And as we go further along, here's our superior semicircular canal arching over, and then our lateral semicircular canal just here. Okay. And we're back on the vestibule. Okay, and we should, in all of those sections, we should see a nice plane of bone around all these structures. So particularly important with respect to the horizontal semicircular canal. Remember, that's quite vulnerable to large cholesteatomas, just as sometimes the other semicircular canals can be as well. And then moving forward from this, so we're going from posterior to anterior. We're now on the round window. So we're just starting off on the basal turn of the cochlea. The coronal images are great for looking at the spiral structure of the cochlea, and you can see this very nicely here. So this is the basal turn of the cochlea. Remember, it makes a bulge into the medial wall of the middle ear cleft called the promontory. This is where glomus tympanicum tumors typically occur. Okay, on the promontory, that's where the nerves of Jacobson hang out, and that's where glomus tympanicums can occur. And then as we move further anteriorly, you can see the spiral shape very nicely. These are the inner turns. So the whole cochlea should have about 2.5 turns, and these are the inner turns just here. The cochlea on axial section doesn't really look like a spiral. It looks a bit like a cauliflower or perhaps a 3-leaf clover, something like that. But you can still see it. That's the sort of structure that we expect to see. That's the opening of the cochlea from the internal auditory meatus. And as we go down, here's the basal turn of the cochlea. That's our round window just in there, that little air-filled niche just at the communicating with the basal turn of the cochlea. Very quickly, let's just whiz through the facial nerve canal. It's got several bits to it. Again, it's a great bit of anatomy to get to grips with. We don't see it within the internal auditory meatus. We know it's there, but on CT, we don't see it. We need MR to be able to distinguish the individual nerves. But once it enters its bony canal, we can make out a labyrinthine portion. We should be able to recognize a geniculate ganglion. And then there's quite a long or horizontal portion, tympanic portion. A posterior genu where it sort of turns right angles to enter the mastoid portion before emerging from the stylomastoid foramen. So here's our internal auditory meatus. We're at the level of the vestibule and the horizontal semicircular canal and the top end of the Otic and the Otitis just here. So here is our comma-shaped labyrinthine portion of the facial nerve canal. And this little blister here is the geniculate ganglion. I suppose you could say that there are two genus, one at the back and one at the front. Okay, so the facial nerve changes direction here. First bit, labyrinthine bit to the geniculate ganglion, and then it turns directly back on itself and is going to pass underneath this structure here, which is the horizontal semicircular canal. So in axial, that's what it looks like. That's the horizontal semicircular canal, geniculate ganglion up at this end, and the posterior genu up at this end. Okay, and what you see the facial nerve canal here very nicely in the middle ear cleft, below the horizontal semicircular canal as that little blister. So sometimes the bony margin of the facial nerve canal is dehiscent, and the nerve actually prolapses down. You can see a discrete soft tissue mass. It's relatively unusual, but you do see it sometimes, and it's an important anatomical variation to point out if you do see it. Moving down, so we're onto the descending portion of the facial nerve canal, or the mastoid portion. This is what it looks like on cross section. Okay, it's just a round blob sitting posterior to the external auditory meatus. And on a coronal image, you can see it. So posterior genu is up here. This is the stylomastoid foramen, and here it is sort of released into the outside world before entering the parotid gland. So some other structures just to be aware of. Don't forget the jugular bulb and foramen, carotid canal, TMJs, and also don't forget the soft tissues beneath the skull base. They can be quite important. So this is a section lower down now. So we're off the middle ear cleft, but we can see quite nicely. This is our jugular foramen, and it's composed of two parts. There's a pars vascularis just here, a little bony spur, and then the pars nervosa. So within the pars vascularis, we have the internal jugular vein and the 10th and 11th cranial nerves. And in this little bit here, it just contains the 9th cranial nerve, but also contains Jacobson's nerves and the inferior petrosal sinus as well. Anterior to the jugular bulb is the carotid canal. Okay, so that's the carotid canal, and there should be a well-defined bony spur separating the two. And the margins of these should be absolutely crisp all the time. Nice corticated bone, even if you've got well-pneumatized mastoid air cells. This is the temporal fissure, anterior end of which is the foramen lacerum, and this sits just below the horizontal portion of the carotid canal. So just above here will be the anterior most part of the carotid canal. And just in coronal, here's our jugular bulb. Okay, it can be very asymmetrical. Okay, it can be virtually non-existent, or it can be huge. And remember, sometimes the margins of it can be dehiscent, and you can see it if you look into the middle ear. And this is quite a sort of well-recognized sort of structure. It's called the jugular tubercle. It looks a bit like an eagle. So laterally, we've got the jugular bulb, and then underneath it, we've got our hypoglossal foramen just in here. It's just quite a sort of recognizable sort of eagle's head appearance of the jugular tubercle. Variations are many, so it's not uncommon to see pneumatization of the petrous apex. Okay, you just have to be aware that whatever can occur in here can also occur in this area here. And it can sometimes produce issues. This is an MRI scan where we've got an area of high signal in the apex of one petrous temporal bone and no signal in the apex of the other. If you do a CT scan, you can see why. One's aerated and one's not. This is normal bone. I suppose on a T1 weighted images, this might represent a cholesterol cyst, and that's why the CT was done. Remember, the jugular bulb can be very large and asymmetrical, and sometimes the bone is thin or even dehiscent. And it does mean you might see a vascular mass if you look through, when you look into the middle ear. Okay, so there's the dehiscent jugular bulb. So in summary, we have beautiful anatomy. It's well worth getting to know. I still think, you know, it's one of the great anatomical areas of the body. You do need a structured approach, I think, to be able to get to grips with it. But the great thing about the anatomy is that once you know where everything is, you can understand more the pathology that tends to occur there. And you know, it makes diagnosis, or at least creating a differential diagnosis, that much easier. We do also need to understand what both CT and MR have to offer. They do run independent to one another in some situations, but they also complement each other as well. Patty, I might just come to you. I've got some cases to show, which would be quite quick, but I'm conscious that we're already at 12 o'clock and we only had half an hour to kick off with. So I'm not sure that I've really got time to do that.
Oh, I think if Mr. Prinsley's happy, we could do a few, yeah. Or would you prefer to do questions?
I'm happy.
Hi, Mr. Prinsley.
Nice to see you, Peter. Shall I just do a quick, this is just going to be, these are going to be very, very quick. Okay. And let's just, I'll do a few. You can tell me to shut up whenever you like. Okay. I won't be offended. So first case, 70-year-old male, conductive hearing loss, discharge, retraction pocket on examination. Okay. And there are a number of radiological findings. So we've got an axial image and a coronal image through the middle ear. And there are three sort of recognizable radiological abnormalities. What I want to know is what those three things are, and also what the underlying diagnosis is. And what is the white arrow pointing to, which is just a bit of normal anatomy. So pencil and paper, you're just going to have to do these really, really quickly, 15 seconds per case. That's what we're going to go on. So you've heard of speed dating. This is speed quizzing now. Okay, so three radiological findings, unifying diagnosis and normal anatomy. 32-year-old female with conductive hearing loss. Okay, I just want the diagnosis. And what is the white arrow pointing to? Again, a bit of normal anatomy. Or at least the arrow is pointing to the normal anatomy, but there's some pathology in there as well. Case number 3. Okay, this is a 10-year-old boy with bilateral sensorineural hearing loss. Axial image through the, well, we can see where we are. We're through the adductors here, so top end of the Otic and the mastoid antrum. What's missing? Question number 1. Question number 2 is, what's the diagnosis? Question number 3 is, what is the underlying cause? And then we've got a white arrow pointing to some normal anatomy and a red arrow pointing to some normal anatomy. What are those structures? I mean, they should all be very, very straightforward after the talk. Maybe not. Next case, number 4, 31-year-old young chap with left ear pain. Okay. And again, I just want the diagnosis, and I want a clinical sign that you might pick up as a consequence of that diagnosis. And there's a white arrow pointing to some normal anatomy. So 3 different things. What's the diagnosis? Clinical sign and normal anatomy. Number 5, dangerous sport, 44-year-old bloke who suffered some conductive hearing loss after playing roly-poly with his daughter on the sitting room floor. So we've got 3 different arrows, okay, all differently color-coded, pointing to different structures. What are those structures? And what's the diagnosis? What would we call this? And how did he do it? I'd have to say the white arrow is quite tricky. So you get an extra 50 points if you get that one right. Case number 6, diagnosis. Sometimes this is a bilateral condition. And in that situation, what underlying condition would you suspect? So what is the diagnosis? What might be an underlying condition, either unilaterally or particularly bilaterally? And then we've got a normal anatomy pointing to an anatomical structure. And I think I better stop there. I've got a few more, but we'll just go back and quickly whiz through those. Okay, it's just a bit of fun, so don't worry about. Here we go. So first case is our 70-year-old male with conductive hearing loss, discharge, retraction, pocket on examination. I guess the radiological findings that I was after is that we've lost our nice pointy scutum here. So we've got erosion of scutum. If we look at the axial images, we can see a soft tissue mass, okay? And this is it on the coronal images. And it's that typical location for a pars flaccida cholesteatoma. So it's a cholesteatoma, and it's also eroding the head of the malleus. You can see it's got a little bite out of the ice cream there. Okay, so somebody's been nibbling at the ice cream. And the white arrow is pointing to the vestibule. Okay, that's the vestibule there. It's the great thing not having any feedback is I can say whatever I like, and it may all just be complete rubbish, but I can decide. So case number 2, diagnosis. Okay, here is our oval window niche. So this is the lower part of the vestibule. We've got a lucency here. That should be nice crisp bone, such as the bone here, but it's not. We've got a lucency here, and it's encroaching onto the footplate of the stapes, which is why they presented with conductive hearing loss. So typical location and appearance of fenestral otosclerosis. And this structure here is a pretty deep sinus tympani. Here's our pyramidal eminence. Okay, facial nerve recess on the other side. This is quite a deep sinus tympani. Number 3, 10-year-old with bilateral sensorineural hearing loss. What's missing? Well, we can see a vestibule, but not a great deal else. So we've lost our horizontal semicircular canal. Okay, we're at the level of the adductors here, and at that level, you should see the horizontal semicircular canal. So it's gone. Okay, so underlying diagnosis, this is labyrinthitis ossificans. This was about 18 months after a severe episode of meningitis. This was bilateral as well. I've only shown you one side. And then a couple of normal structures. We've got the labyrinthine portion, the first portion of the facial nerve canal, just here. And the red arrow is pointing to the endolymphatic sac, or the entrance to the vestibular aqueduct. Case number 4, 31-year-old with left ear pain. And so here's our basal turn of cochlea. Okay, basal, sorry, the coronal images aren't great, are they? But here's our promontory. Okay, there's the basal turn of the cochlea, and we've got abnormal soft tissue just sitting on the promontory. This typical location for a small glomus tympanicum. They can be any size, and typically they tend not to cause bone erosion, but they can cause bone erosion when they're big. And the white arrow is pointing to, or you can either have the long process of the incus or the lenticular process of the incus. Either of those would be fine. Bit of normal anatomy. And we're nearly finished. Okay, so this is the dangerous sport of roly-poly with your daughter on the sitting room floor. So what have we got? Well, this is the incus here. So this is the body of the incus. And to remember, the short process should be pointing towards the mastoid antrum. We don't really see the short process at all. That's the malleus, which is just suspended in the middle of nothing. And that's the long process of the incus, which is sort of trying to make a hole in the facial nerve canal. This is the tympanic portion of the facial nerve canal just here. So we've got disruption of the ossicular chain. Okay, a very abnormally orientated incus. There's the long process. Should be pointing downwards before articulating with the stapes. And on the other side, we've got a little blob sitting in the vestibule, and you shouldn't get little white blobs sitting in the vestibule. So this is actually the footplate of the stapes that's been poked through into the vestibule. Okay. And it was interesting, the rest of the middle ear was completely clear. You know, you wouldn't know anything had been in there. There was no blood, there was no nothing. But this, by the way, is the facial nerve canal, tympanic portion of the facial nerve canal. And this guy had sort of rolled onto one of those wretched hair grips, which had just gone straight into his ear and then straight through his oval window, disrupting his ossicular chain and poking his footplate into his vestibule. So I presume they must have had quite a thick, lush carpet in order for that to have happened. And then finally, we've got this irregular area of bone destruction, rather moth-eaten looking, perhaps some little trabeculations in here. And this is very typical of an endolymphatic sac tumor. Typical location centered on the endolymphatic sac. Okay, it's associated with von Hippel-Lindau. So if it's bilateral, it's von Hippel-Lindau. But there's quite a high association. Quite a large number of patients with von Hippel-Lindau get this abnormality. And it's, endolymphatic sac tumor. And then this was pointing to the geniculate ganglion. Okay, so there's the labyrinthine portion of the facial nerve. This is the geniculate ganglion just here before we get onto the tympanic portion. And that's it. Just a bit of light relief at the end, or maybe a bit of drudgery at the end. As I say, anatomy is the absolute key. Know your anatomy well. You can work out a lot of the pathology, and you also need to know your anatomy in order to be able to work out where the pathology has gone. Thanks very much.